Good morning. It is Thursday, July 8th. I'm Jessica Lovell. Welcome back to the Morning Medical Update. We are continuing our conversation about COVID-19 weight gain and when it is time to include a medical intervention. But as promised, when COVID-19 is grabbing the headlines, so are we. We're grabbing our doctors to talk about what's happening. So let's go straight to Dr. Hawkinson for a look at our COVID count. How did we do overnight?
Yeah, you know, we've been holding steady, again, in that high teens to low 20s. Less is always better, but right now we have 16 active infections with 6 in the ICU. We didn't have any on the ventilator yesterday. We have 1 on the ventilator today. We still have 14 additional recovered patients that are, have met that recovered criteria. So 30 total patients, and then Hays has 2. So we're holding steady. But I did see a patient up on the floors yesterday, otherwise healthy female who's pregnant, who was actually advised maybe not to get the vaccine, which is very unfortunate. She wouldn't have otherwise been in here. So it's just important to really understand that the current medical thinking and what all the medical societies are talking about. We know that our OB-GYN group here is recommending that, but certainly have that discussion with your physician.
All right, so if you have questions for Dr. Hawkinson, now is the time to start sending those in. I do have a couple, though, that were sent to me just to get us started. So Dr. Hawkinson, so yesterday I was listening to the news conference out of Springfield, and those officials there were saying that Mercy Health System, including that Springfield hospital, they're going to start requiring all of their current and future employees to get vaccinated for the COVID vaccine. So what is our status? Could that change? What will go into that decision making? I'm assuming it's once it's FDA approved, of course.
Yeah, right now it's certainly highly recommended. We've heard Dr. Seitz talk about this previously. When it becomes fully approved, we'll have those conversations about making it mandatory. We obviously know the morbidity and mortality, the overall illness and death that these vaccines save, and how safe they are. So we will start to have those conversations once there is approval. We know there are other facilities, institutions that have already made it mandatory. But again, we are going to take that stance once it becomes approved. And we know that with our medical, our physicians here, we certainly know the ID group. I've talked with my colleagues. We fully support making it mandatory here at the health system. So once it becomes approved, we'll have those further conversations.
All right. Also, a couple of people asking about the booster shot. Any updates on if that will be needed and when? One viewer was going to be traveling out of the country and just had some concerns about that. What can you tell us?
Yeah, right now there's no guidance on getting a additional dosing, whether you call that a booster shot. Obviously, we get influenza vaccines every year. We don't call those boosters. So whether it's called a booster or additional dosing, we don't really have a lot of guidance on that right now. We do know and understand, and the data keep pointing towards our immune response from the vaccination lasting for that 6, 8, or almost 12 months. So right now there is no specific guidance. If we do have to get additional dosing, it probably will not be before a year, or if any other pivots in those vaccines. And what I mean by that is if the spike is changed from those vaccine manufacturers, if we need to get it at that time. But right now there is not a lot of expert opinion going around that's saying that we'll need additional dosing any time before a year.
Any reporter questions on the line?
I don't have any back here. I don't know if you have any out front.
All right, if any jump
Charlie
in.
Keegan here.
Hey, Charlie.
Yeah. Hey, I'm from 41. Good morning, guys. Just curious what advice Dr. Hawkinson might give to someone who is traveling to Springfield or maybe the Lake of the Ozarks where we've seen that spike in the Delta variant. What should someone do? Maybe not go there. You tell me.
Yeah, I think the safest thing right now, because again, we've talked about yesterday how it's so important in those geographic areas what those infection dynamics are and understanding that. We know that there is just a high rate of spread right now of SARS-CoV-2 in that Springfield area. If you can avoid that, that would probably be best. But if not, make sure that you're vaccinated. If you go to do things, again, you want to do those same non-pharmaceutical interventions that we've been talking about. Masking is still going to probably be important, especially if you're unvaccinated, but even if you're vaccinated. Distancing if possible. If you're doing out things, obviously if you're at the Lake of the Ozarks, you're probably going to be out on the lake or something of that nature. So if you're doing things, go outdoors to do them. But really, at this point in time, with the high rate of spread, consider maybe changing your plans or not going altogether.
Any follow-up
Thank you.
questions? All right. Anyone else on the line? All right, so be sending in those questions for Dr. Hawkinson. He's going to join us back here in just a moment. But in studio with me this morning is bariatric surgeon Dr. Jennifer Mcallister. Always great to have you.
Good morning. Thanks for having me.
You bet. Okay, and joining us virtually from Springfield, Missouri is Marla Cantwell. She had gastric sleeve 2 years ago. You're going to love Marla. She is very inspirational. You're going to love her story. Right now, though, I want to share these quick stats from the National Institute of Health survey. It had a lot of data, but here are 4 facts that really stood out to me. 1 in 3 adults are considered to be overweight. 2 in 3 adults are considered obese. 1 in 13 adults are considered extremely obese. And get this, 1 in 6 children between the ages of 2 and 19 are obese. Now, 2 years ago, Marla, you would have been among those statistics, but not today, because you underwent a gastric sleeve procedure. So before we talk about that, though, I do want to ask you something. You are joining us from Springfield, Missouri. I just want to find out, how is the COVID spike down there impacting you?
Well, personally, with the spike, I've gone back, and I am fully vaccinated, but I've gone back to double masking. I'm ordering my groceries and picking them up at the local grocery store again. I'm staying home more. And I guess the biggest impact is I stopped going to my local recreation center because I love swimming laps. That's my biggie. So I'm back to working out at home and walking outside.
Yeah, so you're making adjustments as those numbers go up.
Yes.
Thank you for sharing that. So on to food. So some people used food during the pandemic, as we know, as comfort. We all did it in some way or another. You had a sleeve 2 years ago. Was the pandemic challenging for you from a food perspective?
Say no, not really, just because I had my surgery in June of 2019. So by the time COVID hit in spring of 2020, I already had those established routines for eating and exercising. That helped. I was having such great success, and I determined I am not going back to my old eating habits. Having healthy coping skills was key for me. And with all that downtime, I had the opportunity to connect more with family and friends that gave me support. So, and I paid cash for my procedure. So that's a great motivator, friends.
That's right. You're getting your money's worth. I appreciate. Well, and you did all that hard work. So good for you. I love that. It's not always so easy for everyone. Tell me, Marla, how much weight did you lose?
180 pounds in 13 months.
You've got to be kidding me. That's amazing.
Yeah. Nope.
Okay, so you're on this quest to lose, a substantial amount of weight. What sent you to get a medical intervention for weight loss?
One of the first things I did was think about my whys. Why did I want this surgery? And that's so important to figure out your whys. I still have my list, and I still go back and read it. So foremost for me was to get healthy. I wanted to be healthy. I had high blood pressure, not anymore. I had sleep apnea, not anymore. And a family history of diabetes and cancer and heart conditions. I was obese from age 5 till I had the surgery at age 61. Never a healthy weight all those years. So my weight limited me my whole life. I was ready for a change. Ready. Yeah. And
Right.
a new grandbaby. Became
That-
a grandmother for the first time. That was a great motivator too.
I was waiting for that grandbaby to come in there. So, that's. I think what you're telling me though is that you're never too old to have a good quality of life. You've got a lot-
Exactly.
and now you got more years.
Exactly. You are never too old.
All right, so I want to get back with you here in just a moment because you've got some great tips that I want you to share with our viewers because I think we all love to have some good takeaway tips. So don't go anywhere. I want to bring though Dr. Jennifer Mcallister. Good morning to you.
Good morning.
Okay, so do you see a lot of patients like Marla? Is her success rate pretty typical? Talk to us about that.
Yes, well, I have to say that seeing patients like Marla is the best part of my job. how rewarding to be able to help patients and give them a tool that they then make successful and have such wonderful life changes, and to be able to do the things she now does, and to be able to be an active grandmother with her new grandchild. It's just, that's wonderful. And is it typical? Yes, these operations are very successful. I will have to say Marla is a superstar. So she's done phenomenal with her operation. You know, on average, when we talk about these operations, we use a term called percent excess weight loss. So of someone's excess weight, above what we would consider the ideal, how much weight do they use? And so these are averages. But with the bariatric operations, the percent excess weight loss ranges from about 55 up to 80%. If you look at total body weight loss, that ends up being about 25 to 30%. So we use different terms, but certainly Marla is crushing it and doing wonderfully. But on average, yes, these operations, patients can have much success. But you heard all the keys in her story, how the operation's a tool, but she's doing all those other things. You know, she's planning ahead with her grocery shopping. She's now doing it carefully in her home environment to plan ahead and do her grocery shopping. She's not being the victim of those circumstances and just eating whatever's on the shelf and not thinking about it. She did all the activity, she exercised, and she's doing all those things to make this a long-lasting success.
I was going to say long-term process.
Long-term process, absolutely.
How did the pandemic impact your patients?
Well, you know, the pandemic was difficult for everyone, but especially our patients who oftentimes, like Marla describes, the key to success is that patients have to realize they have to be very mindful about this process. It takes planning. You have to plan out your meals. We try to tell patients, don't eat on a whim. Don't pick food decisions when you're stressed. Plan all that ahead of time. Patients had established new lifestyles to where they were more active. Rather than taking the bus to get into work or using the elevator, they walked, they took the stairs. So they increased all of that. So then when patients were staying at home, it took them out of that routine. That routine is what helped them be successful. And so then when they're at home, they're not getting that activity, they're not walking to work, they're not even getting to their car to go to work. And so we didn't have that automatic activity that they had built into life. And then, you know, the saying out of sight, out of mind is very true when it comes to food choices. And so when people were working from home, right next to the kitchen, it was very easy to just mindlessly eat. And so all those systems they had developed to be mindful and develop a strategy for success went out the window. But the key is now it's an important time, not only for bariatric patients, but for everyone to realize, how do I function best? What was that strategy that made me successful? And so really using that as just another tool then for the future of when life throws us a hurdle and it takes us out of our normal routines, what have we learned from this? What do we need to do to get that activity back? What do we need to do to be able to make those smart food choices? And really not seeing this as a failure during the pandemic, but this was an important lesson on what we need to do when life isn't exactly as we planned for.
The new challenge.
Absolutely.
So you saw those stats that we put up here just a few moments ago. What do you think the pandemic is going to result in as far as more people overweight? What are those concerns for you?
Well, the concerns not only in regard to the pandemic, but in general, just every year and every decade, our overweight and obesity rates continue to incline. Those numbers have just gone up and up and up. And so clearly, with advancements in technology and medications, hopefully we can help with that. But it needs to be broad, oversweeping change of food choices for children, more activity for children and adults. So,
talk about the risks of these type of interventions. These are not to be taken lightly.
Absolutely.
A lot goes into the planning and with these patients. Talk to us about that as well.
Yeah, so when we're planning for bariatric operations, you're right, they're not for everyone. Some patients may have medical reasons that they just may not be considered fit for surgery. That's rare, but that does happen, or prior surgical issues that they may not be an ideal candidate. That's where some of the advancements in the medications to help treat obesity come into play, and the lifestyle modifications that come into play. But otherwise, for patients who we would consider kind of ideal candidates, we oftentimes look at what do insurance companies cover. That's kind of where we start those standards. And so, and unfortunately not every insurance company covers that. And so we have stories like Marla, who maybe didn't have that insurance coverage likely, but still knew this was a successful treatment. So we do have cash pay options for those patients who would otherwise be good surgical candidates, but they just don't have the insurance coverage for it. But in general, we use BMI criteria. So BMI is just a number so that we can correlate someone's weight with their height. So in general, for insurance coverage, it's a BMI above 35 if they have comorbidities or other illnesses illnesses that are caused by the obesity. So that's high blood pressure, high cholesterol, hypertension, diabetes, those kind of things. Or a BMI solely above 40. So those are just kind of the general insurance criteria. Now, every insurance is a little different, so those are very broad terms, but those are the general criteria. What we know is that there may be patients who don't fit that criteria. So maybe diabetic patients who have a BMI of 33. We know this still may be successful, but unfortunately, insurance just may not cover that. We want to make sure that patients are in the best state physically, so that they've been optimized by their physician, so that we know they can do well with the operation, and then also in the best state mentally. You know, these operations, it's a big choice. It changes our relationship with food, and so we want to make sure before surgery that patients are at their best spot to make healthy lifestyle changes and really be able to use this tool well.
So Marla had the gastric sleeve, but so did you.
I did, yes. I'm very open with my patients that, yes, I'm not only a bariatric surgeon, but also a bariatric patient. And you know, I find most of us patients have similar stories to where I had tried everything, and I would lose, and then I'd regain more. And I would lose, and I would regain more. And so for me, surgery was the right choice. I had been a bariatric surgeon for years. I knew it was safe. I saw patients who did well, and I saw what they did to do well. And so for me, it was the tool that I needed. And that's the key, is that it's a tool. It came with a whole lot of lifestyle changes to make that tool work and make it a success long term.
And you were 5 years out.
Yes,
And
I am 5 years out.
5
yes.
years of work.
It is 5 years of work, and that's what we always have that discussion before surgery, is that I would love to tell myself, and I would certainly love to tell my patients, that you will never have to worry about your weight again. But unfortunately, that's just not true. Obesity is a chronic and difficult to treat disease, and it's something that we're always going to have to focus on and really kind of transition now into the maintenance of it, like Marla's in now and doing wonderfully with.
Okay, I want to ask you about the new FDA-approved new weight loss medication. This just happened last month. This is the first drug approved for weight loss since 2014. It's called Wegovy.
Wegovy. Yes.
Got it. All right. Pretty darn close. Okay, so it was approved for chronic weight management in adults with obesity ranked as a BMI of 27 or higher, with at least one weight-related condition like high blood pressure, type 2 diabetes, or high cholesterol. The release goes on to talk about patients needing to exercise, of course, to reduce their calories. Those in the study lost between 6% and 12% of their body weight. Is 6 to 12% significant when it comes to better health? I would imagine so.
It is. It absolutely is. And so, in fact, what the studies have shown is that really even at that 5% of total body weight loss is where we see significant improvements in overall health, cardiovascular health, blood pressure, even diabetes control. So yes, 6 to 12% is a wonderful number.
And just quickly, before we get to community questions, how does the medication work and any risks?
Yes, so this medication, it belongs to a group of medications that are called GLP-1 agonists. So a long word, but basically it stimulates a hormone that we naturally have in our gut, in our intestine. And so this works, it is an injectable medication, meaning patients do have to inject it into the subcutaneous tissue in the body. This is once weekly. So there had been previous weight loss medications that work in a similar fashion that were once daily. So with this, you have the benefit of a once weekly injection versus a once daily. And then this indication, again, this similar medication, they've been on the market for a while. The benefit of this is that these studies were looking specifically at weight loss. So now it has that indication. So hopefully insurance will come along with it. And it's a higher dose than what some of these medications were before. Now, are there risks of this? Yes. So this is a medication that works on our intestinal tract, but it also has effects on the brain. So it helps with that, decreasing that appetite stimulation, makes you feel full longer. It slows the emptying of the stomach so that we feel full longer. And it actually stimulates the pancreas to make more insulin, and then it decreases the other tissues of our body that make sugar at other times when we're not eating inappropriately. So not only does it help with weight loss, helps with those drives that make us want to eat more when we're trying to lose weight, and it does have improvement in diabetes management as well. But there are potential concerns with any medication. So certainly this is something that you need to discuss with your physician. Because again, like any of these treatments we've talked about, it's not a magic cure. It's not a magic bullet. It takes those all over lifestyle changes. And that's something that really needs to be done in coordination with your physician. Patients will be much more successful if they're doing this as a comprehensive plan. There's also other medications for weight loss that may be better for certain patients. So specifically for the GLP-1 agonist, although it's rare, they can potentially increase the risk of certain thyroid cancers, what we call medullary thyroid cancers. We've seen that more in animal studies, not necessarily human studies, but it is something to be aware of. And then also going along with that, a rare condition called medullary endocrine neoplasias. So patients with that need to be very cautious with these type of medications. More common side effects, though, tend to be GI side effects. So nausea, kind of dyspepsia, vomiting, can cause diarrhea or constipation. A little more concerning, risk of pancreatitis or inflammation of the pancreas, and it can increase the risk of gallbladder disease as well. So there certainly are things that we need to be watchful of.
A lot of great information. Thank you, Dr. Mcallister. Okay, as promised, we are now ready to take your community questions. Jill, let's get started.
Yeah, we have a lot today too, and they are all based on COVID. So I'm going to start with Donna. She says experts are calling, she read, that Delta is COVID on steroids. What does that mean? Does it mean it's more lethal?
Yeah, I don't think we really know what that means. We've seen this come out as variants have been identified as early as last spring when we had the first D614G variant identified that became the worldwide prevalent variant, and now we've seen others. We don't really understand exactly what that means. Is the virus more fit? So people have said, well, the virus is more transmissible, it causes more disease. We don't fully know the answer to that question yet. Certainly there was a paper out of Scotland produced in the Lancet at the end of June, which showed that people who got Delta variant were maybe more at risk for hospitalization, but that's one study. So we don't fully know the answers to that question. We know that it does evade the immune system, the antibodies, a little bit more than some of the other variants, but yet the vaccines still work. So does it help reduce the immune response like Alpha variant has been shown to do? Does it cause more severe disease? Really, probably not, but we still don't fully know those answers to that question. So we are looking for that. We're trying to get more published data, look to see what is the severity? Does it cause higher rates of death, higher rates of hospitalization? But I think really the one thing to remember about all this, even with Delta variant and the other variants, all of the vaccines that we have for use in the United States still look to protect you against hospitalization and death. And so that really needs to be the main theme as we move forward. I think seeking, asking those questions, does it cause more severe disease? Is it more transmissible? And seeking those answers is a good thing to do. But right now, our best data still show that if you are vaccinated, you are more protected than if you are not. And if you are not vaccinated, you have a higher chance of going to the hospital, of having severe disease, of having death, just as you would with coronavirus throughout this pandemic before vaccine was available.
Karen says that her son got the J&J vaccine, and then she read somewhere that one of our doctors, probably you or Dr. Stites, said that if they got the J&J vaccine, they should get revaxxed with Moderna or Pfizer. Do you want to clarify?
Yeah, I don't think that was us who said that. Our guidance has been what the current guidance is. If you have received 2 doses of Moderna or Pfizer, or if you received the single dose of Johnson & Johnson and you're 2 weeks from those doses, you are fully vaccinated. The best data we have still show that the vaccines do protect you against the wide spectrum of disease, even from the Delta variant, and that especially includes that risk of hospitalization and death. So right now there is no guidance to get additional dosing. We know those questions are being asked, but right now there is no other guidance. You should be just fine, but we will continue to keep up with the literature and the information as it becomes available.
Here's a myth-busting question for you, and it's from Isaac. He said he read that because of myocarditis risk, that no one under 30 should get vaccinated.
Yeah, that's a horrible myth. That's a horrible misinformation campaign if that is going on. In fact, in the MMWR, which is the CDC's publication, they recently published a restatement of what the ACIP, the group that makes recommendations, had said, and that the overwhelming benefits of the vaccination outweigh any of those chances of myocarditis or any heart problems. Those problems are extremely minimal compared to the great benefits of the vaccine. So that is absolutely not true. Anybody who is 12 and over in America with the supply that we have should be getting vaccinated today or as soon as possible.
Nancy says that she knows everyone keeps saying that the vaccines are safe and she should go ahead and get it, but she wants to know, can you assure her that there are going to be no long-term side effects?
I mean, I don't think we ever say never in medicine, but right now there is no evidence of that. Any effects that we would see would really occur within that 4-week time range after getting the vaccination. There is certainly no data signals, even from those trial participants, to suggest that there's any long-term side effects. We don't really see a mechanism for that, even in the mRNA vaccines. That stuff that is injected into you is quickly broken down by your body, so it doesn't stay in your body. The viral vector from Johnson & Johnson vaccine that is injected into you eventually gets broken down as well. There is no plausible mechanism for that, but what we do know is that if you get COVID-19, whether it's asymptomatic, lightly symptomatic, or very severe disease, you have a high risk. 20 to 30% of people after acute COVID have long haul symptoms. And I was just talking with Dr. Comfort, one of our internal medicine doctors who run the long haul COVID clinic for the University Health System. And it's busy. It continues to get busier and busier in those clinics. And the other problem is that if you do have long haul symptoms, many of our patients, 30 to 40% of them, are seeing 2 or 3 specialists for certain things like loss of smell, brain fog, continued shortness of breath, chest pain, also fatigue. So your chance of having side effects and problems afterward is much greater than getting the vaccine. And the new published data also show that you are at a higher risk of having to be rehospitalized within 60 or 90 days after getting COVID and hospitalized for COVID. So there are a multitude of problems much greater than what has been seen with the vaccines if you get COVID-19.
On the topic of long haulers, Rita wants to know, do we know how long hauler symptoms last?
No, we don't. It's quite variable in the literature, and it depends on what symptom it is. Sometimes it depends on the overall severity of disease that you have. But certainly we have seen that 30 days to 6 months or more, those symptoms can continue and persist. But again, in the literature, depending on the individual, it is variable. But just understand that it can last up to months.
Tyler says that the vaccine offers protection for 8 to 12 months. How long am I protected if I just got COVID?
What we have been seeing from laboratory experiments and looking at the plasma, so the blood and the components of the blood taken from those that have been naturally infected, is that you do not have as good of antibody response, especially if you had asymptomatic or mild symptoms compared to those that got vaccinated. So we don't have a specific answer to that question, but what we do understand from the trials that have been going on, those people in the original trials for the vaccine, is that your immunity continues to be robust up until now, which again, if you're a trial participant, is probably almost a year at this point in time. But for what we expect, and if we take into context the normal cough and cold coronaviruses, your immunity, specific immunity for helping prevent those severe illnesses does not last as long, and you can get reinfected and have symptoms, within 3 to 6 months, again, with natural infection. So what we do believe and understand right now is that your durability of immunity from vaccination is greater than with natural infection, especially if you were infected before the beginning of the year, before the Alpha or Delta variant became quite prevalent in the United States.
Okay. Nikki says, what do you think is going to have to happen to these people who refuse to get a vaccination? She says, in order to, move them off the wall and get it, she said it just feels like she's talking to a brick wall.
Yeah, it does feel like that sometimes. Again, we have to keep giving our message. I think some people, it will be different. Some people will have to experience tragedy themselves, whether it's themselves or whether it's their bubble, friends, family members, see and understand what is really going on, what the reality not only there is, but around the world, and what people are having to deal with around the world. Some people, it's still, will continue to do their own research, and eventually their minds will be changed. So again, this goes back down to the individual and just understanding that people have different reasons, and so because of those different reasons, it's going to take different reasons or methods to get those people that are unvaccinated or vaccine hesitant to end up getting the vaccine. If you are in one of those communities that is particularly heavy hit right now, for instance, Springfield, I would hope you would see enough about what's going on around you to understand that you should get the vaccine. Number one, to protect yourself and to protect the people around you as well.
Okay, I'm going to give the last COVID question to Joyce, and then we've got 2 or 3 questions that have come in on topic from today. So Joyce wants to know, Dr. Hawkinson, she says, we have tickets to the Auschwitz exhibit in KC next week. I really want to go, but I'm hearing the majority of people are not wearing masks, and people are very close together. Is it safe for fully vaccinated people to mask up and go?
I think the best guidance right now is, it's safe. If you're vaccinated, you're safe. If you want to take those extra precautions, those non-pharmaceutical interventions, those things that we know work to help prevent disease, then mask and distance as much as possible in that area. But if you are vaccinated, you are safe.
All right, thank you. If another question comes in for COVID, I'll try to scoot it in. But right now, we have got 3 questions from viewers for our topic today. First one is for Marla. The viewer writes, she has such an awesome attitude and she looks so vibrant and healthy. Everyone has ups and downs, though. The list of whys, did they help you get through those days?
Absolutely. Like I said before, I still have my list of whys because that's the motivator that keeps me from going back to where I was. So you got to figure that out. Even if you've already had the surgery and you've had some weight gain, go back and look at your whys. Or if you never did that, write them down. Why am I doing this? Why did I want to make the change? Is it about being healthy? The why is so important.
All right, and Sharon is asking, Dr. Mcallister, is Wegovy effective for people who are taking proton pump inhibitor drugs? How does it affect GERD?
Yes, so Wegovy being a GLP-1 agonist, and again, it's administered subcutaneously. And so still, although I don't know that it was specifically studied for that, would anticipate, yes, it would still be successful in patients who take proton pump inhibitors. It may, however, have worsening effects on GERD. So that's something. Wegovy has doses that start at a small dosage, and then as patients tolerate, they may increase to that maximum dose, which was done in the studies. So there's a variety of GI symptoms, and so that's something that patients who have GERD, they may not have those symptoms at a lower dose and may at a higher dose. But it does not preclude, meaning if someone has GERD, it doesn't necessarily mean that they could not trial the medication.
Okay, and I'm going to have a question from Anil here in a second, and I will ask it, Anil, but I want you to write me and tell me, are you still suffering long haulers? Because we have people that are interested in how long it keeps going on. So anyway, you write to me, Anil, and I'm going to ask Bridget's question, which is, please talk about PCOS syndrome and weight gain. Would this new medication be effective? My loved one eats healthy, exercises, and takes metformin, but continues to gain. It's hard to find a good endocrinologist in the area that specializes in PCOS. Any suggestions?
Sure, absolutely. So PCOS, or polycystic ovarian syndrome, we know that it is it deals with insulin resistance, but then with the endocrine system and the female reproductive system. And so certainly treatments that help improve weight loss and decrease adiposity, or the fatty tissue, can be helpful for PCOS, just like we see in the bariatric operations, how it improves rates or resolution of PCOS. Successful weight loss can also attribute to this. And I would have to say we have fantastic endocrinologists that can help with this. And gynecologists
definitely
as well, who also specialize in treatment of this, and our medical weight loss physicians as well.
Yeah, so give us a call and we'll try to help you with that. And Neil is asking, what is the average cost of surgery and how much recovery time? And Marla might even speak to this, because I think I remember reading that she had a story around trying to find a place to have surgery. What is the average cost? Are you on mute? Marla, are you on mute?
I paid around $10,000 2 years ago. I don't know if it's the same or not, but that was all inclusive, covered everything. And I never even had a chance to check with my insurance because I worked for a school, and the school board specifically excluded weight loss surgery. And I wanted to say, wake up, people, because the cost of all the comorbidities, I just think that the surgery far outweighs what you pay over the long run for that. So anyway.
Did you want to add anything to that, Dr. Mcallister?
Sure, absolutely. Yes. And like Marla said, I think we'll have to take her to the state capitol with us and help us try to make some change here in coverage, because it is important. We know it's a successful treatment. We know it's safe. But unfortunately, not all insurances cover it, or potentially patients don't quite meet those BMI criteria. And so, yes, we do have cash pay options for those patients. As Marla mentioned, for the sleeve gastrectomy, it is approximately $10,000, a little less than that. And then for the Roux-en-Y gastric bypass, it's a little more invasive procedure, so the cost is just a little bit higher. So it's about $15,000 for that operation. But we know it's important for patients that, again, we don't just do the operation and not give them any assistance to be successful. So it is a complete package, including access to our bariatric psychologist, our dietitians, all those other things that are so important, and then also including any laboratory evaluation within that first year of the operation. And so, yes, we agree that it is important. That's why we have that cash pay option. We also would like to advocate for coverage for more patients, because it's an important component of getting back to health. And Marla's right, the cost outweigh the surgical cost by far.
All right, Jessica, I have one more question, and this is on topic, and then you get to take it from here. Nancy wants to know, how are patients' hunger levels after the surgery? She writes, I once lost and kept 50 pounds off for about 10 years, but I was hungry that entire 10 years.
Dr. Mcallister.
Oh, I'm
Any
sorry.
thoughts? That's okay.
Yes. No, I do have thoughts. So our bodies are amazing, and our bodies can be very frustrating as well. And so what we know, some patients will be very successful with diet and exercise alone. But a vast majority, especially if patients have reached those criteria of obesity, the rates of them being successful with that alone are lower, because our bodies strive to keep us at our higher weights. As we lose weight, our bodies set in those hormonal changes to try to drive our weight back up, and you do feel more hungry. The key with these operations is that they actually create hormonal changes that can be long-term. And so we talked about the GLP-1 agonist. Well, that's something that we see with the bariatric operations. It increases that hormone that's released from the gut as part of these operations. And so the key with the operations is that it allows us to take in fewer calories, but still getting in the healthy proteins and the healthy foods we need, but much less, but letting the brain think that we're in a well-fed state. So the brain lets us lose those weight. It doesn't counteract and kick in those mechanisms that try to drive that. So that's why we see that additional success.
Marla, do you have some insight on that? How was it for you? Are you still hungry?
I am never hungry. That's the truth. And I don't know if it's because I've kept on doing the things now that help me lose weight, like specifically eating only small amounts. I don't feel hungry. I feel empty. I don't know how to describe it better, but I feel a little empty sometimes, and that's my cue. It's like it's getting to be time to eat. On my phone, I have reminders to eat.
Wow.
Seriously, because I'm just never hungry.
And that is something we see different in every patient. And as patients get further out from surgery, sometimes those hunger symptoms do come back. And, that's very frustrating for patients, because when they've done these brave and aggressive measures, I'm going to have surgery, that's a big step. It's not something that patients take lightly. And then regaining that weight for patients is terrifying. And so when that hunger comes back, it's a very stressful situation. And so the key is we just go back to the tools. We make sure that patients are planning ahead. Sometimes after surgery, we're even more sensitive to carbohydrates that may make us hungry longer. So it's really getting back to that multidisciplinary team, looking at the foods we're eating. Are we getting back to emotional eating? What do we need to change to readdress? Let's go back to our whys, like Marla said, and get back to why this is important, and let's focus on what made us successful initially. But for some patients, the hunger does come back. Over time, those hormonal changes of the operation, they can fade a little bit. And so these operations, it's not the only treatment, meaning afterwards, some patients may need additional treatments. Some of these medications, like the GLP-1 agonist or multiple other medications, may be helpful for that maintenance. And so that's where we talk about it is a lifelong disease, and it requires that ongoing maintenance. But that feeling of hunger, the feeling of fullness, different for every patient, absolutely.
Sure. Jill, any more questions?
Oh, we're good. We have some, but I think they'll hold for tomorrow.
Okay, sounds good. And I had a viewer that asked me about and I told her I would find out the answer. She was asking how long the wait is for on our transplant list. And so I just wanted to let her know that I have reached out to our transplant team and I'm waiting for that answer. And so I will get that for you tomorrow. So thank you for your question. Okay, so tomorrow we will continue to track the COVID cases near us, of course, as always. We'll also tell you about a little friendly wager we have going with Nebraska Medicine to inspire us to get moving again. We challenged our counterparts in Nebraska to a step challenge. We're going to find out soon if we outwalk the Cornhuskers. So we'll talk about that tomorrow. Now, Marla, please give us some final thoughts for today, and please share your tips for success. We would love to hear those.
Yes. I have loved all the reference to weight loss surgery being a tool, because that's what it is. But you still have to do the work to make it happen. And for me, a big thing was learning new habits to deal with stress and strong emotions and boredom. So those healthy coping skills are huge. I recently had a friend ask me, it's like, how are you maintaining all this weight loss? Because I've been maintaining now about a year. And I said, it's simple. I'm still doing the things now that I did to lose the weight. Ta-da! It's my do's and my don'ts. I don't use a straw. I don't drink soda or any carbonated beverages. I don't ever drink with my meals, and I don't snack between meals. Now, there's a difference. I eat every 3 hours, like a baby, but it's small amounts. And so I don't consider those snacks. I have 5 to 6 meals every day. What I do is I still eat very small amounts. 2/3 to a cup of food is all my stomach can handle. I still exercise 4 or 5 days a week. I still plan my meals, every single meal for a week at a time. I track every single thing I put in my mouth, everything. I take my vitamins every day. I'm very mindful of what I eat. I'm also very mindful of my emotions, what's going on. Because if I feel those stress hormones start to go, it's like I don't turn to food. So what are you going to do? You're going to walk, I color, play with my grandbaby. I weigh once a week without fail. I have a new set point. I'm kind of stuck at 155 pounds, and I'm 5'6", 6.5. But I also want to make sure I don't go under 5 pounds. So the 150 to 160 is my range. And I still believe in myself. That is key.
Wow, I love your tips. I have my phone. I'm going to screenshot your tips so I have them handy with me at all times. Those are great. And Marla, it's just been a real joy to have you on. You're fantastic. We got to have you on more. But I got to tell you that the seeing your side-by-side pictures are great, but just to hear just your quality of life improvement is really the true joy. So we appreciate you sharing your story today. Stay safe in Springfield. We appreciate you sharing that.
Yes.
And Dr. Mcallister, just final thoughts from you today.
Yes, well, I echo everything Marla said. She did a wonderful job of summarizing
She's
that.
the perfect patient.
She really is, yes. Yeah, it makes our job so rewarding, and congratulations. And the key is that all those do's and don'ts that she listed, those don't go away during a pandemic, during holidays. So even a little bit of weight gain, it doesn't have to be something that we're hard on ourselves and we think we can't recover from. We can. Get back to your why, get back to the do's and don'ts, figure out how you live your healthiest life, and we can always get back to that. It's a complex disease. We know it's a lifetime thing, and so we have the resources too. So if this is something you've struggled with, reach out to your primary care physician. There are lots of resources that we can help.
Such great information. Thank you so much for your insight today.
Absolutely.
Dr. Hawkinson, you get the final thought.
I think that's good. You know, we've heard concern about the Delta variant. And is it COVID on steroids? You know, that was a headline going around, had an insightful question about that today. You know, the one thing to remember about that is if you get vaccinated, even with COVID on steroids or the Delta variant, you have protection. You have protection against the whole spectrum of disease. Maybe you do develop some symptoms, but you are significantly protected from seeking medical care, going to the hospital, and of course that severe disease and death. So please continue to talk to your friends and neighbors and people that you know that aren't vaccinated. We do not want to end up like Springfield here in the metro area. We don't want that to happen anywhere. But the way to protect each other from that is to get vaccinated. So continue to talk to people, endorse that message. Vaccination continues to protect against Delta variant.
All right. Thanks, Dr. Hawkinson. And thanks to our guests. We appreciate you being here today. And thank you for joining us. We will see you on Friday. Have a great day.